Good morning. I'm going to do a little filler here while they pull up my slides. Unfortunately, I do have PowerPoints. It's a great pleasure to be here with you this morning. It has also been a great pleasure for me to have worked, to have gotten to know and to have worked with Pam Lane for about 3 months now. We didn't know each other before that. During that time, I've come to learn that we have quite a few things in common, not the least of which is that we are often confused. Since I'm a bit older than Pam, I tend to be confused perhaps more than she is. We, as she mentioned, we do have some common heritage of having been in the United States Navy, and actually I hadn't thought about it that much until just as I was sitting here listening to her comments, how that experience probably influenced and shaped some of my thinking about HIE and electronic health records and use of telehealth and other sorts of things. I was in the Navy, and I was what was called an undersea medical officer, which meant that I worked with divers and submariners and others, and during the time that I was there, there were very few people who had that qualification, so I typically filled, I think the fewest number of billets or jobs was 3, but typically I had 5 or 6 different jobs I was filling, which meant that I was responsible for submarine crews all over the world. My primary responsibility was with what falls under the heading of special operations folks, and I had 45 teams of individuals who were stationed between the Rocky Mountains and Western Asia doing various sorts of things. But they all had health issues, and trying to coordinate and stay on top of their health issues, and particularly when, for example, submarines would go away for long periods of time and you wouldn't know much about what was going on. There was a lot of reasons to have advanced technology to help with that. So, and that probably substantially influenced my thinking. Now, unlike Pam, I do use PowerPoint, and some of it's probably just because I'm getting too old to remember what I'm going to say, but it's probably also a reflection of too many years in healthcare, where every talk, regardless of the subject, begins with the same words: turn the lights off, turn the slides on. And so with that, I'm going to move to the PowerPoint. And it's not long. I have relatively general comments. I'm mindful that the interagency agreement has not been inked and finalized, which does put some constraints perhaps. But the purpose of the talk, I'm not sure why they're not projecting quite the way that they should, but in any case, I want to do 2 things. I want to describe a little bit about what the Institute for Population Health Improvement does, because I suspect most of you, if not all of you, are not familiar with that entity. It's a new entity and has a perhaps nice sounding name, but doesn't tell a lot necessarily about what it does, so I'm going to share a little bit about that. And then I'd like to offer a bit of a preview of some of the things that might be reasonably expected after the transition of the activities to the Institute. So, the Institute for Population Health Improvement, it is part of the University of California Davis Health System. It was established in March of 2011, just a little more than a year ago. Since it was established, we've developed a pretty diverse portfolio of activities that currently is somewhere a little north of $80 million worth of grants and projects and other sorts of things. We consider ourselves and function, much of the work that we do, as I'll illustrate in a moment, is that we serve as a resource for healthcare reform, for health policy, and for clinical quality improvement, reflecting a lot of where I've spent most of the past 35 years or so. We are actively engaged in assisting government, federal, state, local, particularly health-related agencies in designing, implementing, and administering various programs. We really want to focus particularly on the many determinants of health. In healthcare, people too often get lulled into thinking that health is about health care. And the data shows quite the contrary, that health care, at least on a population basis, has relatively little to do with health. There are a lot of other things that are very important in determining health, from education to employment to environment and other things that I won't go into here. But when we think about health, we really have to think about the totality of one's experience. And that's certainly important in public policy, where healthcare costs are zooming up and consuming a greater and greater proportion of our tax dollars, often and perhaps increasingly so, are disproportionate to where we might achieve better health benefit in the long term by focusing on some other things, but that's a topic for another conversation. We're focusing on building healthcare leadership and health management capacity, and we really want to use data. Much of my mantra over the years has been about evidence-based clinical care, evidence-based policymaking, and so we really think that we have to mine and use, leverage data in more creative ways going forward. Indeed, I would posit that any healthcare system that's going to be successful in the future has to be very competent in population health management, because increasingly we have to focus on managing the health of populations. However those are defined. They may be defined by geography, by race or ethnicity, by clinical condition. There's lots of ways that you can define population, but we have to focus on the population as well as the individual, and that's one of the major changes that we're seeing in healthcare reform. Obviously, because we are part of an academic health system, we also conduct research and involved in teaching as well. Some of the activities, just to illustrate some of the work that we're doing, by no means a complete listing, but we are working with the Department of Healthcare Services in what's known as the Medi-Cal Quality Improvement Program, designing a quality improvement effort for Medi-Cal in general, a $50 billion a year program, and increasing significantly every year, as well as a part of that, some of the federal dollars coming into California called the Delivery System Reform Incentive Pool, DSRIP, which is about a $3.3 billion coming into California for that. We've recently taken over management or administration of the California Cancer Registry. This is somewhat ironic because I actually was instrumental in getting the legislation passed to authorize statewide reporting of cancer in 1985, and then implemented the registry statewide in 1988. So I don't know, I guess it comes back to get punished for that. But an interesting sidebar there, which is relevant to something that Pam said, is there's also work going on for a stroke registry. And recently, there's been some additional funding made available for that. We're talking with the Department of Public Health about how we might help in that effort, since it's using the same platform as the California Cancer Registry, and there's a number of other things that would make it would make a lot of sense in moving those things in parallel, with the idea also that we need to be thinking about a number of other statewide registries for diabetes and heart disease and some other things as well. We're managing now a number of public health programs for the Department of Public Health, the heart disease and stroke prevention programs, arthritis, various eating healthy, it's one I need to read the book better, I guess, and active living programs, the Every Woman Counts program and breast and cervical cancer screening for underserved women, tobacco control, and there's some others that we're talking about as well. We're also have just started doing a statewide assessment of surgical adverse events and trying to improve surgical safety with the Department of Public Health, recognizing there's a lot of work already going on in that regard, and so we'll be marrying up those efforts with what's going on with the California Hospital Association and others. Have funds for a number of research projects. We're also discussing and at various stages of evolution in a number of other programs that are either federally or state funded as a result of healthcare reform. And we've recently also taken on a new project of investigating the potential for what's called community paramedicine in California. That's an evolving concept where paramedics who are very highly trained in emergency and acute care may be used more broadly to satisfy other community health needs. It's an interest that is evolving in a number of other states as well as other countries. Again, somewhat the irony, in the early 1980s, I wrote all the regulations for paramedics and EMTs and trauma centers and whatnot. So again, this is kind of an interesting coming full circle. And last but not least, we are obviously at an advanced stage of discussion with the health, I always say Health and Welfare Agency, but it's no longer known by those terms, the Health and Human Services Agency, on the HIE program, which is obviously is the focus of our discussion today. So hopefully you have a little better sense of what the Institute is, some of the work that it's doing, and why there is some intuitive and other nexus with HIE and what we're doing. So let me shift gears and talk a little bit in admittedly general terms about what might be expected after this transition. Although I want to just provide a little bit of context for that before I do so. I was reminded after a talk, I don't know, a little bit ago, since I came back to California, where I had been talking about actually open source health information technology and some of the issues related to that, and someone in the audience came up to me afterwards and said, you know, that sounds an awful lot like a talk that I heard you give in the 1980s as health director. And so I mentioned, you know, my interest in health information technology and how it can be used is not new. Indeed, when I was director of the Department of Health Services, the predecessor agency to 3 agencies today, the Department of Healthcare Services, the Department of Public Health, and Cal EPA. One of my great joys as health director was cleaning up Superfund sites and other things, which I was happy to pass on to Cal EPA. But anyway, a couple of the projects that we funded related to HIE and trying to marry together different databases at that time were very promising and consistent with some of the things that we're talking about today. Unfortunately, they didn't have as good an outcome as I had hoped, and some of them were carried on largely after I had left the department, in probably a significant part because the technology just wasn't there. And after $20 or $40 million of investment, it became clear that it just couldn't get there with the existing technology. But the world has changed a lot since then. When I went to the VA in the mid-1990s and was asked basically by President Clinton and Secretary Brown whether this entity could be salvaged or not, laid out a strategy, had a number of strategic objectives. One of them was to modernize information management technology, and I was pleasantly surprised that VA had actually done a lot of work and was well ahead of the community at large, or healthcare at large. It took a couple of years, but we launched in 1997 the implementation of VISTA, the VA's electronic health record. I know many of you are familiar with VISTA. And over the next 3 years, implemented it, went live in 172 hospitals and a much larger number of facilities overall. I think it remains the largest and most rapid and most successful deployment of electronic health record anywhere in the world. But as a result of that, it also became very clear what the benefit was to improving quality, because concomitant with a number of other things, quality in the VA healthcare system improved dramatically. Indeed, in some articles that were published after I left VA in Business Week and Fortune and other such periodicals that aren't known to be complimentary to government ever, they actually, headlines best medical care or best health care in the US, talking about the VA. And a lot of the focus there was on implementation of electronic health record and what it could do. And while I don't want to dismiss that, it does simplify it, because the promise of the electronic health record has to be embedded in a system that has a number of other things. Being mindful of the clock, I'm not going to go into that here, but I would just highlight that when I left VA and went to establish the National Quality Forum, which is all about improving healthcare quality in the United States, one of the things that we did early on was to call for a national summit on HIE, health information technology in healthcare. And the reason for doing this is to make a point. This was just 10 years ago. And at that time, this was viewed as somewhat radical. We had the summit, and it was published by the National Quality Forum. One of the things that resulted from that, then I went to meet with Secretary Tommy Thompson. Some of you may remember when Secretary Thompson was at the helm of the Department of Health and Human Services. And in a one-on-one meeting, which actually there's never a one-on-one meeting with the Secretary. He had 4 or 5 other people, but that was about as close to a one-on-one as you get. I advocated and went through a number of things about why he should embrace electronic health records and all the other IT and make that a hallmark of his tenure as Secretary, to which he, after politely and patiently listening to me for whatever it was, 20 or 30 minutes, told me he thought it was the dumbest blank idea he had ever heard, and that no one would ever remember him as Secretary for giving doctors computers. And he just thought it was stupid. But we persisted, and there was actually a White House fellow there who was a physician who got it. We continued to press the point, and he actually came around, and to his credit, he became a major advocate and enthusiast for HIT, which then led to the establishment of the Office of the National Coordinator and targets that were espoused by President Bush and others. But again, the point is that that was just about 10 years ago. And I guess as you get more white hair, you begin to think that 10 years is shorter than when you're on the south side of 60, I guess. But in any point, a lot has happened, and this continues to be a very rapidly evolving field. And that's, I guess, the point that I want to make, is that things are moving so fast that we continually have to reappraise and relook at what we're doing to make sure that where we're going is consistent with the state of things at that moment in time, because the environment and the universe is changing dramatically. So, what might you expect after this transition? Well, we're going to continue to focus on the deliverables that are in the ONC grant. Pam, I think, made clear that those are must-dos, and we will continue to focus on the strategies to get there. We're going to continue to solicit stakeholder input. I'm very mindful for many years in working in California how diverse and large it is, and the need that we need to be continually informed by the many different interests that exist in the state. We do feel, and I think that will be expressed as we move forward, a sense of urgency. And I think you can expect that this will become more tangible. Not exactly sure what that means, or at least at this point, but there will be a more tangible sense of urgency in how we approach things. We also think that there needs to be perhaps greater focus on the integration of HIE and HIT with other public health and healthcare reform initiatives that are underway, particularly thinking about things like the California Coordinated Care Initiative, or also known as the Medicare-Medicaid Dual Eligibles Project that's going to be embarked upon in 8 counties in a few months. The Deseret program, and there are a number of others that might fall into that category. We also need to focus on HIE as a tool, not as an outcome. And I know that's embedded in what has been said, and it's embedded in the words, but too often, and I say this also as having been the CEO of an IT company, I have sat on the boards of IT companies, we get fixated on the technology and sometimes lose sight of the fact that the technology is a means to an end. It's simply a tool to help us accomplish other things, and we continually have to keep those other things very much in our thinking. We are going to be questioning past strategies and tactics, not because we think they are at all wrong, but as I hopefully have made the point, very rapidly changing world, rapidly changing environment, we continually have to ask ourselves if what we're doing today is consistent with the circumstances of today as opposed to yesterday. We think we really have to have greater connectedness between the private initiatives in HIE that are underway and the publicly funded ones. With 5 expansion grants, 16 or so other HIEs that are underway, we really need to be working very closely. We have to, much attention is focused on sustainability, and quite appropriately so, but the way we get to sustainability and having a sustainable business model is to be able to demonstrate value and something that people want to pay for, because it does have to be paid for, and the government is not going to continue to pay for things in perpetuity. And so while we have an opportunity now to fund some things, get the things started, we really have to be very mindful of the need that this has to be sustainable. We have to have a sustainable business model, and we do that by demonstrating value. We really want anecdotes and stories to help better communicate with the public at large, with the professional community, with others about why HIE is important. I suspect I'm preaching to the converted here, but not everyone's converted. And there are still a lot of heathens out there, if you will, to use that metaphor. And the way that we convert them is through stories and understanding what this means for ordinary patients, for ordinary doctors, for others, and indeed, having spent many years as an emergency physician, I can think of incredible ways that this would have been helpful at various times over my career. Just 2 other points I would make before closing with one final thought is that we will be looking for a new name for the entity. We have a candidate name, but I am not going to share that with you at this moment. We would like to steal any good ideas that anyone else might have. So we are accepting suggestions for what the name of the new entity should be. And we will accept those through the end of August or about, and you can submit your suggestions through either of the 2 websites that are listed up there. Hopefully you can read them. If not, we'll make them otherwise available. And we also, just on a small housekeeping or pragmatic, we will be relocating the office, the primary office to Sacramento, and there will be some personnel changes just because of the relocation and other things. But you know, I don't think that comes as a surprise, or should come as a surprise to anyone. So the last thought I would just leave you with is this. It applies not only to HIE and health information technology in particular, but healthcare reform and healthcare in general. We are in a very rapidly evolving and changing industry or sector. And what we used to think was the future yesterday is likely to be very different tomorrow, and we, again, continually have to keep that in our thinking. So with that, thank you very much for the opportunity to be here, share a few thoughts. I think I'm told that my time is exhausted, so I will sit down. Thank you again.
Great. First of all, please join me in thanking Dr. Ken Kizer. And of course, Pam Lane, Deputy Secretary. We're very, very pleased with what you've been able to share with us today. We do have microphones in the audience. I'm going to cut in a little bit to the time that Libby's taken to moderate the next panel. Is there any quick question from anyone in the audience that we want to get on board? Also, I'm going to ask Taha and Lynette to go ahead and amble up here. Any questions? All right, you guys were so overwhelming in your presentation, Pam and Ken. We are stunned and amazed. We're thrilled. Oh, go ahead. So Pam's going to ask a question again. Go ahead.
No, I'm really not going to. I do want to, though, tell you the one concluding comment that my father made, and that was, it's going to be hard, and when it gets hard, and I'm sharing this with you because I want you to say this to yourselves, when you have those days, you say, oh, man, this is awful. Take a deep breath and then say to yourself, this is when the fun starts. So this is when the fun starts.
Absolutely. Thank you. And we are going to have fun at this, and we have had. So thank you both very much. Oh, yes, you want to come on up to the microphone? Right over here?
On the side.
Keep walking to your left. You're getting warmer. You're getting warmer. Hot, hot. You got it. Thank you, Sajid, our high-tech support here.
Put me on the spot.
It may
Activate. If you give it to Sajid, you know you're in trouble.
There you go.
You can just repeat the question.
Sure, we'll do that.
Thank you. Now that Cali Connect is within population health, is there any chance for population health grant funding, particularly to combine a lot of what we're doing with HIE with, for instance, underserved communities like in the Central Valley with asthma, including clinical decision-making software on analytical software on HIEs, etc.
Well, that provides me an opportunity to reinforce a point that I made, is that we think that there has to be greater connection between HIE efforts and other public health and healthcare reform efforts. So the short answer to your question is yes, we do, and we'll be looking to how we can connect these things. How that's going to happen and the specifics of where and when and with what dollars is to be determined. But conceptually and philosophically, that will be a high priority as we approach things, is how do we use this tool to accomplish other public health and healthcare ends. Again, it goes back to the point that we have to focus on what the real goal is, and it's not the technology, it's how we improve health of people.
I think one of the most important things to remember too is that we are dedicated to working smarter, not harder. We can't work any harder, so we've got to work smarter. And the smarter way to do this is to look at where we cut across populations, whether it is vulnerable populations, and who in our world today isn't vulnerable. Vulnerable includes rural, it includes all the ones that we traditionally think of in public health as well. But I think leveraging the activities and the opportunities that we have to actually look at things from a bigger perspective is exactly what we're going to have to do.
The mic is working.
Oh, Sajid, our hero.
Okay, any other comments or questions? That has been very helpful. Thank you both very much for your time today. And
Thank you.
You'll be here throughout. Be sure to grab them while you can. Thank you.